Welcome to the Deep Dive, where we cut through the complexity of critical topics, extracting those golden nuggets of knowledge you need to be truly well-informed. Today, we're diving deep into a field where every single second, every decision carries immense weight: vascular trauma.
Yeah, absolutely.
This isn't just about understanding an injury, it's about mastering time-critical, life and limb-saving decisions.
Indeed. Trauma remains a major global public health challenge, and vascular trauma, well, it represents its most acute and demanding frontier.
Right.
We're talking about scenarios where rapid, evidence-based choices are absolutely paramount to prevent catastrophic hemorrhage, acute ischemia, and, devastating long-term disability.
And for you, our dedicated listener, whether you're meticulously preparing for a high-stakes exam like the FRCS or simply striving for a rapid consultant-level understanding of this complex area, this deep dive is custom-tailored. Our mission today is to arm you with the latest, most pertinent insights from the European Society for Vascular Surgery, or ESVS 2025 Clinical Practice Guidelines on the Management of Vascular Trauma.
Right.
We'll distill the highest yield topics, unpack the nuances of these critical recommendations, and discuss what they really mean for clinical practice.
Exactly. My aim today is to guide you through these guidelines, focusing on their practical application. Think of this as a consultant's perspective, emphasizing time-critical decision-making, strategic prioritization, understanding the specific recommendation classes and evidence levels, and crucially, identifying common pitfalls, all essential for any surgeon and certainly for success in the FRCS examination. So let's unpack this crucial material together. Throughout our discussion, we'll refer to ESVS recommendation classes and levels of evidence. Just to clarify for everyone, Class I signifies a strong, unequivocal recommendation. Class I suggests it should be considered, and Class I indicates it may be considered.
Okay, good reminder.
And regarding evidence levels, Level A means it's supported by high-quality evidence like randomized controlled trials, whereas Level C often relies on expert consensus, observational studies, or smaller patient series.
Right.
This framework helps you understand the strength behind each piece of advice we'll be discussing.
All right, let's begin with a macro perspective. Who is most vulnerable to vascular trauma, and what are the typical scenarios leading to these critical injuries? It's always foundational to grasp the scope of the problem first.
Yeah, definitely. From a global vantage point, vascular trauma epidemiology is remarkably varied. It's profoundly shaped by a multitude of factors, including population demographics, the specific mechanism of injury, and the healthcare environment itself, whether we're talking about a bustling urban center, a remote rural setting, or even a military theater. For anyone preparing for the FRCS, recognizing this inherent variability is the initial step towards developing a truly comprehensive and adaptable approach.
That makes perfect sense. So with that variability in mind, what does the data tell us about the common profiles we encounter in practice? Who are we seeing most often?
Well, broadly speaking, vascular injuries account for approximately 2% to 5% of all trauma admissions. The highest incidence is typically observed in young males, which, well, isn't entirely surprising given the demographics often involved in high-energy trauma.
Right.
However, it's a critical distinction for the FRCS. Geriatric patients, though fewer in number, about 0.7% of those aged 65 and above, compared to 2% in younger adults, they tend to present with more severe overall injuries and are often victims of blunt traumatic vascular injuries.
Okay, so older patients, more severe blunt injuries.
Exactly. Children, on the other hand, represent a smaller fraction, with vascular trauma occurring in only about 0.6% of all pediatric trauma patients. Yet, their management presents its own unique set of challenges, demanding specialized considerations due to their distinct physiology and, the long-term implications for growth and development.
Fascinating. So, different age groups clearly bring different challenges to the table. And how do these devastating injuries typically occur? What are the predominant mechanisms you see, and how do they inform our initial approach?
The mechanism of injury is profoundly influential, often dictating the severity and location of the vascular damage. Consider urban environments, for example. Penetrating injuries, predominantly from firearms or knives, are unfortunately common. These mechanisms carry a significant vascular trauma burden, with studies showing up to 16% of gunshot patients having at least one vascular injury. Tragically, when vascular repair is required, these injuries are associated with higher mortality rates.
Right.
Conversely, blunt trauma, often the result of high-impact motor vehicle collisions, falls from significant heights, or industrial accidents, is more prevalent in rural areas.
Okay.
Patients sustaining blunt trauma generally present with more severe systemic injuries and, unfortunately, a higher rate of limb amputation compared to those with penetrating vascular trauma, despite often not having immediately obvious external bleeding.
That's a stark contrast. Sure. So where do these injuries typically manifest in the body? Is there a common anatomical pattern that every trauma surgeon should be acutely aware of?
Absolutely. Anatomical location is a crucial aspect of the initial assessment. In civilian settings, the extremities are most commonly affected, accounting for about 44% of vascular injuries, roughly split between the upper and lower limbs.
Okay, nearly half.
Yeah. This is followed by the torso, with the abdomen at 25% and the chest at 24% and the neck around 10%. It's also vital to distinguish that blunt trauma, due to the forces involved, often leads to more central vascular injuries, such as those involving the torso's great vessels.
Right, the big ones.
Exactly. Penetrating injuries, in contrast, frequently affect the extremities and what we term gential regions, areas like the base of the neck, axilla, or groin, where the torso transitions into a limb.
And when we talk about damage, what exactly are we seeing at the vessel level? Does it range beyond a simple tear?
Oh, definitely. The pathology at the vessel level is incredibly diverse. It can range from a direct vessel transection, which is typical with a sharp knife injury or a high-energy gunshot wound, to indirect injury caused by energy transfer, especially prominent with high-velocity projectiles. In blunt trauma, the mechanism is often stretching or impingement of the vessel wall, leading to an intimal tear, which can then progress to dissection or subsequent thrombus formation.
I see.
It's absolutely critical to remember that these vascular injuries rarely occur in isolation. They frequently present with associated orthopedic trauma. For instance, a fracture of a long bone can directly lacerate or contuse adjacent vessels.
Right, like a displaced femur fracture.
Precisely. Underscoring the necessity of a meticulous clinical examination both before and after any fracture reduction. In the thorax, the shear deceleration forces can cause blunt aortic injury, most commonly at the aortic isthmus, while in the abdomen, seatbelt injuries can lead to direct aortic damage. This complex interplay of injuries demands a holistic diagnostic and therapeutic approach.
That paints a vivid picture of the diverse challenges. What then are the overarching foundational principles for managing these patients? For an FRCS candidate, it's about having a rock-solid, actionable framework.
The bedrock principle here is highly organized, multidisciplinary trauma care. This is truly not a solo endeavor.
Yeah.
The ESVS guidelines emphasize that trauma system centralization is a Class I recommendation supported by Level C evidence. This means having rapid 247 access to a clinical team profoundly competent in both open and endovascular hemorrhage control.
Both open and endo, okay.
Yes. This team must be genuinely multidisciplinary, encompassing vascular surgeons, trauma surgeons, anesthesiologists, interventional radiologists, and other critical specialists. Furthermore, the implementation of dedicated vascular trauma curricula and continuous training is also a Class I recommendation, Level C.
Great.
This commitment ensures that both decision-making acumen and technical skills are honed and maintained precisely the standard expected for the FRCS.
So an integrated team and continuous specialized training are absolutely foundational. Once that system is in place, what's the immediate initial assessment strategy for the patient themselves?
That leads us directly to the ABCDE approach, the standardized rapid initial evaluation protocol. However, for patients presenting with exsanguinating injuries, we crucially adopt the CABCDE approach.
The ABCD.
Yes, where the initial C stands for catastrophic hemorrhage control, unequivocally emphasizing immediate and definitive bleeding control as the absolute overriding priority.
Got it. Stop the bleed first.
Exactly. Following this, damage control resuscitation, DCR, integrated with massive transfusion protocols, is a Class I recommendation, Level A, for actively bleeding vascular trauma patients. This paradigm is transformative. It focuses relentlessly on preventing and treating coagulopathy, integrating permissive hypotension, rapid hemostatic resuscitation, and timely damage control surgery.
Right. Stabilize first, definitive repair later if needed.
Precisely. The goal is to stabilize physiology before attempting definitive repairs.
And are there specific pharmacological interventions that are universally recommended to aid in bleeding control during this critical phase?
A truly excellent and critical question. Tranexamic acid, or TXA, is a pivotal, time-sensitive intervention. Early administration of TXA is a Class I recommendation, Level A, for all severely bleeding patients with vascular trauma.
Class I, Level A. High recommendation.
Very high. This must strictly follow the CRA CHADE 2 protocol guidelines. The deep insight here is that TXA is not just another drug. It's a critical early intervention that can significantly reduce mortality by stabilizing clots and preventing hyperfibrinolysis, especially when administered within the first 3 hours post-injury.
3 hours. Key window.
It's a non-negotiable step in damage control resuscitation.
So we've tackled immediate catastrophic bleeding, often through direct pressure or the CABCDE pathway. Now, let's talk about temporary measures that can bridge us to definitive care and then the crucial diagnostic steps. For the FRCS candidate, this is where knowing specific recommendations and, just as importantly, the contraindications truly comes into play.
Absolutely. This is where a consultant's critical thinking shines through, extending far beyond rote memorization. For temporary bleeding control, tourniquets are a Class I recommendation, level C, for uncontrolled extremity bleeding where direct compression or packing proves insufficient.
Okay.
The key is to apply them as distally as possible, ensuring frequent checks for effectiveness, and crucially, removing them as soon as feasible under controlled conditions in the operating theater. This buys time for definitive repair without prolonged ischemia.
Right. But what about heparin with tourniquets? I feel like that's a potential pitfall.
It is a critical contraindication. Heparinization with tourniquets is a Class IIIA recommendation. Level C heparinization is not indicated as part of tourniquet management for uncontrolled bleeding.
Okay, Class 3 not indicated.
Exactly. The focus here is solely on hemorrhage control. Administering heparin under these circumstances would be a significant and potentially detrimental pitfall, as it would exacerbate bleeding once a tourniquet is released, or even beforehand if systemic.
That's a vital distinction. And what about REBOA, resuscitative endovascular balloon occlusion of the aorta, which has garnered so much attention in trauma circles? What's its place in these new guidelines?
Yeah, REBOA. It has indeed been extensively investigated for temporary hemorrhage control in non-compressible torso trauma. However, its position in the guidelines reflects a more sober, evidence-based assessment. It is a Class V recommendation, level B.
By Dave, so not recommended routinely.
Precisely. REBOA is not recommended as a routine approach. The real insight here is that while it holds appeal in extreme crises, recent randomized controlled trials suggest it may not reduce mortality and could even increase it, with an estimated 8% vascular complication rate.
Wow, okay.
Its use should absolutely not delay definitive hemorrhage control, and the challenge of appropriate patient selection remains significant. For the FRCS, understand that REBOA is a highly specialized tool with a very narrow indication, not a default.
Understood. Not a routine solution, and perhaps even a demotion from earlier perceptions. Once we have a hemodynamically stable patient, how do we achieve a definitive diagnosis? What's the go-to imaging modality now?
This is definitely FRCS high yield. Computed tomography, angiography, or CTA is unequivocally the gold standard.
CTA.
CTA, encompassing both arterial and venous phases, is recommended as the first-line investigation to identify or definitively rule out vascular injury in hemodynamically stable trauma patients without active, uncontrolled bleeding.
Okay. Stable patients only.
Correct. This is a live recommendation, level C, primarily because its sensitivity and specificity in detecting vascular injuries approach 100%. It gives us the precise roadmap we need for surgical planning.
So if a patient is unstable, time for CTA is simply not an option. They go straight to the OR.
Precisely. For unstable patients unsuitable for CTA, the recommendation is immediate transfer to the operating room for surgical intervention. This is a Class I recommendation, level C. In these dire circumstances, diagnostics cannot, under any circumstances, delay life-saving surgery. The clock is ticking, and the priority is direct hemorrhage control.
What about concerns regarding contrast-induced nephropathy, particularly in patients with pre-existing renal impairment? Is that a reason to delay a CTA?
Another crucial point to clarify, and often a source of debate. A contraindication here is delaying CPA due to renal impairment. It's a Class V recommendation, level C.
I've again, so don't delay.
Exactly. Avoiding or postponing CTA in hemodynamically stable patients with potentially life or limb-threatening vascular injuries is not recommended. The risk of acute kidney injury from contrast, while real, is exceedingly low compared to the catastrophic risk of a missed severe vascular injury that could lead to loss of life or limb.
Okay.
Clinical judgment must prioritize the immediate threat.
So given the dominance of CTA, what role do other imaging modalities like ultrasound or conventional angiography play in the acute diagnostic phase?
For other modalities, their role in the acute diagnostic phase for vascular trauma is largely limited. Fast or focused assessment with sonography and trauma can quickly identify free blood in body cavities, but cannot precisely localize or characterize vascular injury sites.
Right, just sees fluid.
Exactly. Duplex ultrasound, or DUS, is highly operator dependent and, in the urgent trauma setting, often not available or reliable enough within the required time frame. Digital subtraction angiography, or DSA, while once the gold standard, has largely been replaced by CTA for diagnostic purposes due to its invasiveness and longer procedure time.
But still has a role sometimes. Intra-op, maybe.
Yes, DSA still retains a vital role intraoperatively, particularly for confirming repairs or facilitating endovascular therapeutic interventions like embolization.
So once we've identified and precisely localized an injury using CTA, how do we classify it? And crucially, how does that classification guide our next steps for repair? This sounds like a core framework, especially for the exam.
It is. This brings us to the ESVS arterial injury classification, a key framework for management, particularly critical for the FRCS examination. This systematic approach guides decision-making based on the increasing severity of arterial wall disruption and the corresponding risk of hemorrhage or vessel occlusion.
Okay, let's break it down. Grade 1.
Grade 1. This involves an intimal injury, a tear or flap, but with a normal external contour of the vessel and preserved flow. These are typically managed non-operatively with antithrombotic therapy and close surveillance.
So watch and wait with meds.
Essentially, yes. The deep insight here is that not every vascular injury requires immediate surgical intervention. Sometimes a watchful waiting approach with medical management is both safe and effective.
Okay, grade 2.
Grade 2. Here you'll observe external wall disruption, but critically, the bleeding is contained, often manifesting as a pseudoaneurysm or an arteriovenous fistula. These require urgent repair, as the containment is precarious and carries a significant risk of delayed rupture or expansion.
Urgent repair for grade 2. Got it. Grade 3.
Grade 3. This signifies a complete transection of the vessel with active free bleeding. This is an immediate, life-threatening, emergency-demanding emergency repair. The priority is immediate hemorrhage control and restoration of flow.
Emergency repair makes sense. And grade X.
Grade X. This grade denotes complete vessel occlusion, typically due to thrombosis following a less severe injury or direct transection. Emergency intervention is required if the limb or end organ distal to the occlusion is salvageable and viable. The distinction from a grade 1 is crucial. Grade X means no flow.
Okay, clear category. So once classified, what's the priority in restoring flow and what techniques are recommended?
In terms of restoring perfusion and surgical techniques, the primary focus, without any equivocation, is on speed. The ESVS guidelines state that prioritization, restoration of inline arterial flow, whether temporary or definitive, is a Class A recommendation, level C, and must be prioritized in limb or end organ threatening vascular trauma.
Class A again. Restore flow ASAP.
Absolutely. Any delay can lead to irreversible damage, underscoring the time is limb adage.
So definitive primary repair is always the ultimate goal, but sometimes, in the chaos of trauma, temporary measures are essential, almost a bridge.
Precisely. Definitive versus temporary. Primary definitive repair is unequivocally recommended over temporary solutions. A Class I recommendation, level C. However, and this is a crucial nuance for the FRCS, temporary vascular shunts are recommended to rapidly restore blood flow in the extremity when timely. Good question. For graft reconstruction, when a direct primary suture repair isn't possible, short interposition grafts are recommended, Class 1, level C. This is common. Regarding the graft materials themselves, while there's no high-quality evidence definitively favoring autologous over synthetic in all emergency situations.
Right. Level A evidence is lacking.
Exactly. Synthetic interposition grafts may be considered for emergency definitive repair, Class II, level C. This is particularly true when autologous vein, the patient's own vein, is limited or for very rapid flow restoration in a life-threatening situation.
Okay, so synthetic might be faster in a pinch.
It can be. However, vein grafts should be considered for longer bypasses or small caliber distal vessels, Class II, level C, where their superior patency rates and infection resistance, especially in contaminated fields, make them more critical for long-term success.
Makes sense. This whole approach sounds incredibly demanding. Needs a big team, right?
It absolutely does. The necessity of a truly multidisciplinary team encompassing general surgery, vascular surgery, interventional radiology cannot be overstated. These cases are rarely straightforward.
Yeah.
Furthermore, emergency access to an operating room with hybrid capability, meaning it's equipped for both open surgical and endovascular procedures simultaneously, is a Class I recommendation, level C.
Hybrid or R. Essential.
It facilitates these complex multimodal approaches, allowing surgeons to pivot between techniques as needed, which is often crucial in the unpredictable environment of trauma.
Now let's pivot our focus to an anatomical region where vascular injuries carry truly profound and often delayed neurological consequences.
Yeah.
The neck. What's fundamentally crucial to understand about cervical vascular trauma?
Yeah, cervical vascular injuries are indeed high stakes. Their proximity to critical cerebral structures means that even subtle injuries can lead to devastating, often delayed neurological deficits.
Mm.
In our approach, we fundamentally differentiate between penetrating and blunt mechanisms, as these distinct injury patterns guide our diagnostic and therapeutic strategies in very different ways.
Let's first delve into penetrating injuries. How do these typically present, and what's the recommended management pathway from the ESVS guidelines?
With penetrating cervical vascular injury, PCVI, the clinical presentation can vary dramatically, from immediately obvious to deceptively subtle. You'll be looking for hard signs which mandate immediate surgical exploration.
Okay, what are those hard signs?
Things like active pulsatile hemorrhage, a rapidly expanding or pulsatile hematoma, refractory shock despite resuscitation, an absent distal pulse, a palpable vascular bruit or thrill, or clear signs of acute neurological deficit like hemiparesis.
Right, hard signs mean straight to OR.
Exactly. Soft signs, such as minor hemoptysis, dysphonia, or dysphagia, are more subtle indicators that warrant further investigation. Critically, stroke is a deeply feared and often delayed outcome, sometimes manifesting hours after the initial injury.
And for diagnosis, particularly with modern imaging, do we still use the old three-zone approach for penetrating neck injuries?
Not really as the primary diagnostic tool anymore. We now strongly advocate for a whole neck approach rather than relying on the older three-zone classification, especially given the widespread availability and high diagnostic accuracy of CTA.
Okay, so whole neck CTA.
Yes. The zones were a useful concept before advanced imaging, but wound tracks, as you know, don't respect arbitrary anatomical boundaries. For patients presenting with active bleeding or overt hemodynamic instability, immediate surgical exploration is required. There's no time for imaging.
Right.
However, for all other stable patients, CTA is recommended as the primary diagnostic imaging, Class 1, Level BC. This allows us to precisely map the injury, assess its severity, and plan our intervention with much greater confidence.
Okay, let's get into the granular specifics of management by ESVS grade, as this is FRCS specifics for penetrating injuries. Let's start with the carotid artery.
Right. For a carotid artery injury, Grade 1, intimal tear or flap. For these minor injuries, often resulting from a projectile passing close by, non-operative management with single antiplatelet therapy may be considered. Class IB, Level C.
Just antiplatelets for grade 1.
Often, yes. The rationale is to prevent thrombus formation and allow for spontaneous healing. Grades 2 and 3, wall disruption with contained or uncontrolled hemorrhage. This is a critical distinction. Reconstruction, rather than ligation of the common or internal carotid artery, is a Class I recommendation, Level C, when patient physiology allows, and it's technically feasible.
Repair over ligation, Class I. Why is that so important?
Because the deep insight here is profound. Ligation carries a significantly higher risk of stroke, and death rates can be as high as 45% mortality with ligation versus 17.6% with repair in some series.
Why big difference?
Huge. Furthermore, studies show up to 80% of patients with preoperative neurological deficits demonstrate improvement after successful repair. This recommendation fundamentally mandates prioritizing long-term neurological function, even if it adds surgical complexity.
Okay, crucial point. What about grade X, carotid occlusion?
Treatment for an occluded carotid is highly individualized. This requires careful consideration of factors such as the timing of injury, the presence and duration of neurological symptoms, the precise location of the occlusion, common versus internal carotid, the extent of the occlusion, and critically, the risk of reperfusion injury or evidence of pre-existing brain infarction on initial CT imaging.
So, no simple answer for grade X.
No, it requires nuanced, multidisciplinary discussion.
That's a lot for the carotid. What about penetrating vertebral artery injuries? They seem trickier to get to.
They are. For vertebral artery injury, Grade 1, intimal injury. Similar to the carotid, non-operative management with single antiplatelet therapy may be considered Class IB, Level C, for asymptomatic patients. Grade 2, wall disruption, contained hemorrhage like pseudoaneurysm or AVF. Endovascular therapy, specifically embolization or covered stenting, should be considered as the first-line treatment for symptomatic or progressing injuries, Class III, Level C.
Endo first for vertebral grade 2.
Because surgical access to the vertebral artery, particularly in its bony course, is notoriously challenging and carries high morbidity. The good news is that vertebral artery sacrifice, often achieved via embolization, is generally well tolerated if the contralateral vertebral artery and the posterior circulation are demonstrably intact, with reported rates of postoperative stroke around 4%.
Okay, often okay to sacrifice one if needed.
Often, yes. Grade 3, uncontrolled hemorrhage. Emergency endovascular management with embolization is recommended if feasible, Class 1, Level C. If endovascular options are unavailable or fail, surgical ligation may be necessary due to the severe life-threatening bleeding risk. Grade X, occlusion. Non-operative management with single antiplatelet therapy should be considered for asymptomatic patients, Class TI, Level C. Given the rich collateral flow in the posterior circulation, many asymptomatic occlusions do not require intervention.
And finally, for penetrating venous injuries in the neck, like the jugular, do we always repair?
For cervical venous injury, ligation is recommended if repair of an internal jugular vein injury is not easily achievable, provided one internal jugular vein remains patent, Class 1, Level C.
Ligate if one side is okay.
Generally, yes. If both are injured or there's significant cerebral venous hypertension, repair of at least one should be attempted. The external jugular vein, however, can generally be ligated without any significant long-term consequence.
That's an incredible amount of intricate decision-making for penetrating injuries. Now, let's shift to blunt cervical vascular injuries, which often present very differently and can be far more insidious, lurking without immediate symptoms.
Blunt cerebrovascular injury, BCVI, is indeed another FRCS high-yield area, and its presentation stands in stark contrast to penetrating trauma.
Right. How so?
For blunt cervical vascular injury, BCVI, clinical presentation. Critically, most patients are asymptomatic on presentation, with the injury detected incidentally during imaging for other trauma.
Asymptomatic. That's scary.
It is. The insidious danger here is a delayed stroke, which can occur hours or even days later due to thromboembolic complications stemming from an intraluminal dissection or pseudoaneurysm. Active free bleeding is exceedingly rare, unlike in penetrating injuries.
Okay, so delayed stroke is the big worry. How do we find these then?
Diagnostic imaging and screening. CTA, extending comprehensively from the aortic arch to the intracranial vessels, is the unequivocal diagnostic modality of choice. Class 1, Level BC.
CTA again, arch to brain.
Exactly. Given the often asymptomatic nature of BCVI, screening protocols such as the modified Denver criteria, which include risk factors like Lafort fractures, severe traumatic brain injury, cervical spine fractures, or seatbelt abrasions with altered mental status, should be considered for patients with blunt trauma and these risk factors. Class DA, Level C.
So screen high-risk patients even if they look okay.
That's the key. This proactive screening is crucial for identifying these silent injuries early.
And can we rely on just a clinical exam for blunt neck trauma?
Absolutely not. Contraindication. Clinical exam alone, a crucial point for the exam. Clinical examination alone is not recommended to rule out cervical vascular injury in blunt neck trauma, Class 5, Level C. Relying solely on symptoms is a major pitfall given the high rate of asymptomatic injuries.
Okay, I don't rely on exam alone.
Got it.
So how do we manage these blunt carotid and vertebral injuries, again by ESVS grade?
Right. For blunt carotid artery injury, by ESVS grade, Grade 1, intimal tear, dissection, intramural hematoma, non-operative management with single antiplatelet therapy is a Class I recommendation, Level C.
Antiplatelets again for grade 1.
Yes. Many of these minor lesions, if stable, can heal spontaneously or stabilize with this approach, preventing propagation of thrombus. Grade 2, external wall disruption, pseudoaneurysm. Non-operative management with antithrombotic therapy remains the dominant approach. Delayed endovascular treatment may be considered for enlarging pseudoaneurysms or if neurological symptoms develop, Class II, Level C, but this is a highly selective decision, usually after a period of medical management.
Mostly medical for grade 2, too. What about routine stenting?
No. Contraindication. Routine stenting. Routine endovascular stenting as an adjunct to antithrombotic therapy is not recommended for grades 1 or 2 without active bleeding. Class 3, Level C. The natural history often favors healing with antithrombotic therapy alone, and stents introduce their own long-term risks.
Okay, avoid routine stents, grade 3.
Grade 3, uncontained bleeding. This is rare in blunt trauma but requires urgent intervention. Operative treatment with either open repair or endovascular stent graft is recommended, Class 1, Level C.
And grade X occlusion in blunt carotid.
Grade X, occlusion. Non-operative management with single antiplatelet therapy should be considered for asymptomatic patients, Class 3I, Level C. For symptomatic patients, management is highly individualized based on the acuity and severity of neurological symptoms, the duration of occlusion, the risk of reperfusion injury if intervention is attempted, and critically, CT signs of pre-existing brain infarction, Class 3, Level C. Revascularization in the setting of established infarction carries significant risk.
Very complex decision for symptomatic grade X and for blunt vertebral artery injuries. Similar approach.
Pretty similar for blunt vertebral artery injury, grades 1, 2, or X, without active hemorrhage. Management with antiplatelet therapy as first-line treatment is a Class I recommendation, Level B. Similar to carotid injuries, pseudoaneurysms in the vertebral system often have a benign course and heal spontaneously.
Antiplatelets first for most blunt vertebral.
Yes. Grade 3, uncontrolled hemorrhage. Emergency endovascular management with embolization, if feasible, is recommended, Class I, Level C. Surgical options are generally reserved for failure of endovascular techniques due to the challenges of anatomical access.
Given the primary concern of stroke, what's the main strategy to prevent these devastating neurological complications in BCVI patients? Anticoagulation or antiplatelets?
Antithrombotic therapy is the cornerstone for stroke prevention in BCVI. While various agents have been used, a recent meta-analysis showed a lower bleeding risk with antiplatelets compared to anticoagulants, odds ratio 0.29, and single antiplatelet therapy is generally favored.
Okay, antiplatelets generally preferred over anticoagulants.
Yes, but the decision to initiate any therapy must be carefully weighed against any potential bleeding risks from concomitant injuries, especially an intracranial hemorrhage, which is a common and often overriding contraindication for full anticoagulation.
Right, always balance the risks. And finally, after initiating non-operative management for these blunt injuries, what about long-term follow-up to ensure stability and healing?
For blunt carotid artery injury, grade 1 or 2, undergoing non-operative management, CTA surveillance at 1 week and 3 months should be considered, Class CIA Level C, to assess for resolution or progression.
1 week and 3 months.
Yes. The aim is to confirm stability or healing of the lesion. Long-term follow-up beyond 3 months is less clearly defined by evidence, but spontaneous resolution of these lesions typically occurs within 3 to 12 months.
Moving into the chest, blunt thoracic aortic injuries are notoriously lethal, often claiming lives before the patient even reaches the hospital. What are the key considerations and immediate priorities here?
You're absolutely right. Blunt thoracic aortic injury, or BTAI, carries an extremely high pre-hospital mortality rate, with up to 80% of patients tragically dying before hospital arrival.
80%. Staggering.
It is. For the fortunate few who do make it to the hospital, the risk of free rupture is highest in the initial hours, making immediate and decisive management absolutely critical.
So for those who do make it, what's the very first critical step in managing these highly fragile patients?
For the vast majority of BTAIs that are identified, often incidentally on imaging for other injuries as they are frequently asymptomatic, the immediate clinical focus is strict control of systolic blood pressure, aiming for a narrow window of 90-110 mm Hg, and heart rate, keeping it below 100 beats per minute.
BP 90-110, heart rate under 100.
Correct. This is a Class I recommendation, Level C, for untreated BTAI. The objective is to minimize shear stress on the injured aortic wall, thereby reducing the risk of propagation or rupture.
Unless there are exceptions.
Yes. This protocol applies unless the patient presents with hypovolemic shock or a concomitant traumatic brain injury, where different blood pressure targets may be necessary to ensure adequate cerebral perfusion. Beta blockers are commonly employed to achieve this hemodynamic control.
And where should these critically ill patients with BTAI ultimately be managed? Does it need a specialized center?
Definitely. Referral to a trauma center with 247 multi-specialty expertise in aortic pathology is a Class I recommendation, Level C. These are complex, high-stakes injuries requiring the full resources of a specialized team equipped for advanced aortic interventions, both open and endovascular.
Can a simple chest X-ray reliably rule out such a devastating injury? It's a question that often comes up in early trauma assessment.
Yeah, and it's a critical point for FRCS candidates. Chest X-ray is not recommended as an imaging technique to exclude BTAI, Class 5, Level B, due to its notoriously low sensitivity.
Okay, Class 3 again. Chest X-ray is out for ruling out BTAI.
Correct. Relying on it alone would be a significant and dangerous oversight. CTA is, again, the diagnostic standard.
And how do we classify the severity of these aortic injuries? Does it follow the SVS grading?
Yes, the ESVS grading system for BTAI aligns precisely with the Society for Vascular Surgery, or SVS classification, which is essential to understand for the FRCS. Grade 1, SVS 3. This represents a minor injury confined to the intima or the vessel wall with a normal external aortic contour. Includes intimal tears, intramural hematomas, grade 2, SVS 3. Here we see an external contour abnormality or external wall disruption, but crucially, the hemorrhage is contained, typically as a pseudoaneurysm. Grade 3, SVS 3. This is the most severe form, indicating complete wall transection with active free rupture. This carries the highest immediate risk and demands immediate aggressive intervention.
Okay, grades 1, 2, 3 minor, contained rupture. That grading provides clarity, but the optimal timing of intervention can be incredibly complex, right? Often influenced by other injuries. What's the guidance? This is another FRCS focus on timing.
Indeed, timing is paramount, and it's where sophisticated clinical judgment comes into play. Grade 1, minor injuries. Non-operative management with meticulous blood pressure control and follow-up imaging, specifically a repeat CTA within 48-72 hours to assess for stability or progression, is a Class I recommendation, level C, for patients without concomitant severe traumatic brain injury.
Okay, watch and wait for grade 1 if no severe TBI.
Right. Many of these minor injuries, like small intimal tears, will resolve spontaneously. However, in patients with severe TBI, where maintaining a higher cerebral perfusion pressure is paramount and tight blood pressure control on the aorta is challenging, endovascular stent graft repair may be considered, Class I level C, to allow for these higher cerebral perfusion pressures without risking aortic expansion.
Interesting nuance for TBI patients. What about grade 2, the pseudoaneurysms?
Grade 2, pseudoaneurysms. Endovascular stent graft repair, or TVAR, is generally indicated for these. The timing, however, is nuanced. Delayed 24-hour TVAR should be considered for patients with grade 2 BTAI without high-risk features, Class II LLC.
Delayed TVAR if no high-risk features. What are those features?
These high-risk features, which you'll find detailed in Table 10 of the guidelines, include things like systolic BP consistently below 90 millibreach G, a large mediastinal hematoma, a left hemothorax, evidence of aortic coarctation, or the presence of traumatic brain injury, all indicators of more severe systemic trauma.
Oh, so if they have those features.
Then urgent repair. Urgent 24-hour TFAR is recommended for grade 2 BTAI with these high-risk aortic features, Class Y level C. The evidence here is compelling. Judicious waiting for delayed repair in stable patients has actually shown survival benefits, allowing for optimization of the patient's overall condition before a major intervention.
So delay can actually be better sometimes if stable.
Exactly.
And grade 3, free rupture.
Grade 3, severe injury active extravasation. For these most severe injuries with active free rupture, immediate operative repair is a Class I recommendation, level C. There is simply no room for delay.
Endovascular repair, TVAR, has undeniably revolutionized this field, becoming the dominant treatment for many BTAIs. What are the key details and practical considerations for candidates to know about the operative approaches, particularly regarding TVAR?
TVAR has indeed transformed the landscape. It is the preferred modality for most BTAIs involving the descending aorta, consistently demonstrating significantly better early outcomes compared to open surgical repair, with lower mortality rates and fewer devastating complications like paraplegia and stroke.
But it's not without risks, right? What are the common complications?
True. While generally safer, TVAR is not without its own set of device-related complications, including endoleaks, access site issues, especially with peripheral vascular disease, occlusion of the left subclavian artery, LSA, and rare but serious device collapse or migration.
What about heparin during TVAR? Always use it.
Intraoperative heparinization. This should be considered on an individualized basis, Class II level C. The decision is a delicate balancing act, weighing the risks of bleeding, especially in patients with TBI or multiple injuries, against the risk of periprocedural thromboembolic complications. There is no one-size-fits-all answer here. It requires astute clinical judgment.
Individualize heparin, okay, and sizing the stent graft.
Stent graft oversizing. Oversizing the stent graft between 20% and 30% should be considered, Class II level C, when the initial CTA was performed during hypovolemia.
Why oversizing if they were hypotensive?
Because hypotension can lead to an underestimation of the true aortic diameter, and inadequate oversizing can result in endoleaks or even device collapse.
Ah, makes sense. What about covering the left subclavian artery, the LSA? Do we need to revascularize it?
Left subclavian artery, LSA management. This is a nuanced area often tested. Routine LSA revascularization is not indicated with coverage during TVAR, Class III level C.
Okay, routine revascularization is out, Class 3.
Right, as many patients tolerate its occlusion without symptoms. However, LSA revascularization is recommended for selected patients at risk of compromised perfusion to critical areas like the brain, heart, internal mammary artery for a coronary bypass, or spinal cord, class 1, level C.
So revascularize selectively based on risk.
Exactly. Furthermore, delayed LSA revascularization should be considered if ischemic symptoms, such as arm claudication or vertebrobasilar insufficiency, develop after LSA coverage, class 3, level C.
So TEVAR is often the first choice, a real game changer. But open surgical repair still holds a place in the algorithm. When would open repair be the preferred or necessary approach?
Open surgical repair, OSR, is still recommended for selected patients with an aortic anatomy unequivocally unsuitable for a stent graft, class 1, level A.
Such.
This could be due to a lack of an adequate proximal or distal landing zone for the stent graft, or severe small diameter or diseased iliofemoral vessels that preclude safe endovascular access. For example, a very young patient where long-term durability is paramount, or a highly angulated arch, might push towards an open approach if feasible.
And if an open repair of the thoracic aorta is performed, what's absolutely crucial to prevent a devastating complication like paraplegia?
This is an absolutely vital consideration. For spinal cord protection during OSR, active distal aortic perfusion is recommended to minimize the risk of paraplegia, class I, level A.
Active distal perfusion, class I, level A. Better than clamp and sew.
Significantly superior to older methods like simple clamp and sew or passive shunting, which carry much higher rates of spinal cord ischemia due to prolonged periods of no or inadequate distal perfusion. Active perfusion methods, however, do necessitate systemic anticoagulation, which must be managed carefully.
Given the lifelong implications of these severe injuries, especially in a younger trauma population, what about long-term follow-up after these complex interventions?
Long-term surveillance is crucial, particularly for a trauma population that is generally younger and has a long life expectancy.
What's the recommended schedule?
For patients who have undergone TEVAR, follow-up CTA or MRA is recommended at 1 month, 1 year, and then annually for at least 5 years to monitor for device-related complications or progression of aortic pathology.
Okay, 1 month, 1 year, then yearly for 5 years after TEVAR, and non-op.
For patients managed non-operatively, an MRA is recommended at 1 month, then yearly until complete remodeling of the aortic injury is observed.
And MRA is preferred long-term.
Yes, critically, MRA is recommended as the preferred imaging method for long-term surveillance, class Y level C, to significantly reduce radiation exposure in these younger patients. However, we must acknowledge a practical challenge. Compliance with long-term follow-up can often be difficult in trauma survivors due to a myriad of socioeconomic and psychological factors.
Are there any specific recommendations for other thoracic vascular injuries beyond the descending aorta, such as those involving the arch vessels?
Yeah, while less common than BTAI, injuries to aortic arch vessels, such as the innominate artery or the proximal left common carotid artery do, occur and require tailored approaches. The treatment choice between open surgical and endovascular repair should be considered based on the patient's hemodynamic status, the specific anatomy of the injury, and any concomitant injuries.
Class 2I, level C.
Okay, tailor the approach for arch vessels. What about the subclavian artery?
For subclavian artery injury, endovascular stent graft repair should be considered the preferred treatment modality for grade 2 and 3 injuries requiring operative treatment. Class 2I, level B. Primarily due to the considerable technical challenges and higher morbidity associated with open surgical access in this deep anatomical region.
The abdomen is another region where vascular trauma demands immediate and often incredibly complex interventions. What are the key points for FRCS candidates regarding these abdominal vascular injuries, particularly given their high stakes? Abdominal vascular injuries are, thankfully, generally rare, but they are absolutely associated with an exceptionally high mortality rate, particularly with penetrating mechanisms.
Right.
For the FRCS, it's vital to recognize that these injuries are almost invariably associated with multiple other severe abdominal and visceral injuries, making the clinical picture exceedingly complex and challenging.
What are the most commonly injured vessels in the abdomen, and how do patients typically present clinically?
The most frequently injured vessels include the aorta, the superior mesenteric artery, the iliac arteries, the renal arteries, the inferior vena cava, and other major abdominal veins.
Okay, the big ones.
Yeah. Clinically, patients typically present with overt signs of active bleeding, whether it's into the abdominal cavity or retroperitoneally. The patient's hemodynamic status, whether they are stable or in profound shock, is the overriding primary determinant for deciding between immediate transfer to the operating room for surgery or, if stable, proceeding with diagnostic imaging.
And what's the go-to diagnostic imaging for these injuries, assuming the patient is stable enough for it?
Once again, CTA is the primary imaging investigation for abdominal vascular injuries, providing optimal visualization of both arterial and venous structures with high fidelity, class I level C. This allows us to precisely localize and characterize the injury before intervention.
This brings us to a crucial intraoperative decision point, especially relevant for the FRCS. How do you manage a retroperitoneal hematoma when you've already opened the abdomen? It's a moment of significant clinical judgment.
It really is. This is an FRCS high-yield topic, demanding astute intraoperative decision-making. The management of a retroperitoneal hematoma encountered during laparotomy requires very careful consideration. Unstable patients. For patients in profound shock with ongoing hemorrhage and a high suspicion of a major abdominal vascular injury, immediate surgical exploration and aggressive hemorrhage control are recommended, class I level C.
Explore if unstable.
Yes. Here, damage control principles, including resuscitative packing and direct aortic compression, are essential to gain rapid control of bleeding and stabilize the patient's physiology. Stable patients. Conversely, and this is a critical distinction, a non-exploratory approach to retroperitoneal hematomas during trauma laparotomy with subsequent CTA imaging is recommended, class I level C, for patients who are hemodynamically stable and have a stable retroperitoneal hematoma.
Stable meaning?
Meaning it is not actively expanding, not pulsatile, and not clearly actively bleeding. This allows for a more controlled, targeted intervention based on precise imaging findings, avoiding unnecessary exploration that could destabilize the patient.
Okay, don't explore a stable hematoma initially. Get the CTA first.
Correct. Exploration techniques. If exploration is required, it typically utilizes specific medial visceral rotations for optimal exposure. A right medial visceral rotation provides access to the IVC, infrarenal aorta, iliacs, and right renal vessels. A left medial visceral rotation offers access to the celiac mesenteric aorta and left renal vessels. For pelvic hematomas, exploration often begins over the common iliac artery bifurcation to control the internal iliac artery origin.
Let's delve into specific abdominal arterial injuries, starting with the abdominal aorta itself.
Okay. For abdominal aorta injuries, minor injuries, grade 1. For blunt minor injuries without ongoing bleeding, non-operative management with surveillance and antithrombotic therapy is a class I recommendation level C. These intimal injuries often heal spontaneously. Severe injuries, grade 3, with free hemorrhage and instability. Open surgical repair is recommended as the first-line treatment, class I level C.
Open repair for unstable grade 3 aortic injury. What kind of graft?
Critically, synthetic graft material is recommended for aortic reconstruction in these emergency situations, regardless of concomitant bowel injury, class 1 level C, due to its immediate availability and ease of rapid placement.
Synthetic is okay even with bowel injury. That's important.
Yes, class I recommendation. Endovascular repair. For hemodynamically stable patients with grade 2 injuries showing an external contour abnormality or pseudoaneurysm, endovascular stent graft repair should be considered, class I level C. As with thoracic injuries, stent graft oversizing of 20–30% should be considered when initial imaging was performed during hypotension, class I level C, to ensure adequate sizing and prevent complications like endoleaks.
What about iliac artery injuries, which are frequently associated with severe pelvic trauma?
Right. For iliac arteries, grade 3, common or external iliac. Primary surgical repair, synthetic interposition graft reconstruction, or vascular shunting is a class I recommendation level C.
Repair or shunt? What about ligation?
Avoid it if possible. The deep insight here is that ligation of the common or external iliac artery carries exceptionally high mortality rates, often 30–90%, and limb amputation rates as high as 54%, so it must be avoided if at all possible.
Okay, ligation is really a last resort for common external iliac. What about bleeding from the internal iliac, common in pelvic fractures?
Pelvic injuries. Endovascular treatment with embolization is recommended for patients with pelvic injury and clinical signs of ongoing bleeding or extravasation from the internal iliac artery or its branches. Class 1 level B.
Embolization for internal iliac bleeding.
Got it. It's a highly effective, minimally invasive way to control hemorrhage in this often difficult to access region. Grade 2 or 3. Common or external iliac. For stable patients, endovascular stent graft repair should be considered, class I level C, as a viable alternative to open surgery, especially given the challenges of open pelvic exposure.
And what about the mesenteric arteries, which are absolutely critical for bowel perfusion?
For mesenteric arteries, inferior mesenteric artery, IMA, ligation is recommended for injury to the IMA, class 1 level C.
Ligate the IMA. Why?
Because its territory is typically well collateralized by the superior mesenteric artery system, and ligation is a quicker, safer option in an emergency.
Okay. What about the SMA, the superior mesenteric?
Superior mesenteric artery, SMA, grade X, occlusion. Endovascular stent or stent graft repair may be considered to achieve early restoration of bowel perfusion, class I at level C, given the dire consequences of SMA occlusion for bowel viability. For grade 1 injuries to the SMA, non-operative treatment, though lacking robust evidence, seems a reasonable approach, similar to other minor intimal injuries.
Now, a very specific and often high-stakes scenario for both life and kidney function, renal artery injuries. What's the precise guidance here, particularly for the FRCS high-yield points?
Indeed, renal artery injuries have some very specific high-yield considerations that an FRCS candidate must master. Unilateral devascularized kidney. First, revascularization of a devascularized unilateral kidney, meaning one identified on CTA as completely lacking perfusion, is not recommended. Class 3A, level C.
Don't try to save a completely devascularized kidney if the other side is okay. Why not?
The crucial insight here is that due to prolonged warm ischemia time, the renal damage is almost certainly irreversible, and attempts at revascularization are unlikely to salvage function and can instead increase patient morbidity.
Okay, class 5, futile and potentially harmful. What if the patient is unstable with a severe renal artery injury?
Grade 3, severe unstable. For a hemodynamically unstable patient with a grade 3 injury, ligation of the renal artery with or without simultaneous nephrectomy is a class A recommendation, level C. In these circumstances, life takes absolute precedence over kidney salvage.
Ligate or nephrectomy if unstable. Got it. What if it's bilateral injury or injury to a solitary kidney?
Bilateral grade 2, 3, or X, or solitary salvageable kidney. In these truly critical situations where the patient has bilateral injuries or injury to a solitary kidney that is salvageable open or endovascular renal artery repair is a class I recommendation, level C. The imperative here is to preserve renal function and avoid dialysis.
Okay, try to repair if bilateral or solitary. What if they're stable with a grade 3?
Grade 3, stable. For hemodynamically stable patients with an ESVS grade 3 injury, open or endovascular renal artery repair should be considered, class 3, level C. Similarly, endovascular stent graft repair should be considered for stable patients with grade 2 injuries, such as a pseudoaneurysm, class 3, level C.
Finally, what about the major abdominal veins, particularly the inferior vena cava, IVC, and other large venous structures? Repair often seems more technically demanding than arterial.
It can be for inferior vena cava, IVC, and major abdominal veins, abdominal venous injury. Generally, vein ligation is recommended if primary repair is not easily achievable, class 1, level C. Venous repairs, especially in a contaminated trauma field, can be more technically challenging and prone to thrombosis than arterial repairs.
So ligation is often okay for abdominal veins.
Often, yes. IVC injuries. Non-operative management with close observation and follow-up imaging should be considered in hemodynamically stable patients with a stable retroperitoneal hematoma, class DI level C. Not every contained hematoma needs to be explored. Operative management. Minor IVC injuries can be repaired with simple lateral venorrhea. For more complex injuries or in an unstable patient, ligation of the IVC, especially infrarenal, may be an acceptable damage control option. However, it carries its own risks of leg edema and renal dysfunction.
Is atriocaval shunting ever used for IVC injuries?
No. Contraindication. Atriocaval shunting. Atriocaval shunting is not indicated in the management of IVC injuries, class 3, level C, due to a history of poor outcomes and the extreme complexity of the procedure in a trauma setting.
Okay, class 3, no atriocaval shunts. What about portal or mesenteric veins?
Portal vein and superior mesenteric vein. Injuries to these vital veins are associated with notoriously high mortality rates, ranging from 40% to 72%. Ligation is a reasonable damage control option in a hemodynamically compromised patient, though primary repair is attempted if possible and patient stability allows.
And renal veins.
Renal veins. Repair by venorrhea is generally preferred. Ligation of the left renal vein is often tolerated due to extensive collateral outflow, but ligation of the right renal vein usually results in irreversible kidney loss, similar to an arterial occlusion.
To extremity vascular trauma is perhaps unsurprisingly the most common type, and the decisions made here often dictate a patient's long-term quality of life and functional independence. What's the fundamental overarching approach to these limb-threatening injuries?
You're absolutely correct. The extremities are the most frequent site of vascular trauma, carrying a substantial risk of both amputation and long-term functional deficits. The overarching principle, ingrained in every trauma surgeon, is crystal clear. Prioritize rapid revascularization.
Right.
Time is limb is not just a saying, it's a medical imperative.
So how do we begin that initial assessment in the emergency department? What's paramount in the physical examination, and what insights should we be looking for? This seems like core FRCS stuff.
It is. A careful clinical vascular examination is a Class I recommendation, level C, in all patients with extremity trauma. This is FRCS high yield. You're meticulously looking to identify potential hemorrhagic signs active, pulsatile bleeding, or rapidly expanding hematoma, or crucially, ischemic signs.
The 5 Ps.
Exactly.
Right.
An absent pulse, delayed capillary refill, pallor, paresthesia, excruciating pain, or paralysis, the classic 5 Ps, although some texts use 6 Ps. The absence of these signs, particularly a palpable pulse, is vital.
And what's a crucial insight from that initial physical exam? Is there a reliable sign that can help triage rapidly?
The crucial insight for an FRCS candidate is that the presence of easily palpable, symmetric peripheral pulses in both the injured and uninjured extremities can, in many cases, reliably rule out a significant flow-limiting vascular injury, potentially saving precious time and avoiding unnecessary imaging.
Okay, palpable pulses are reassuring, but
But this must be interpreted with caution. Accompanying nerve injury, especially in complex orthopedic trauma, can mask or hinder evaluation, so clinical suspicion must remain high, and a missed injury is devastating.
what about using the ankle brachial index, or ABI, to diagnose these injuries? It's a common tool in other vascular settings.
Yeah, but not here. This is a key contraindication for the FRCS. An ABI is not indicated to diagnose or rule out significant vascular injury in patients with extremity trauma, Class 3, Level C.
Okay, ABI is out for trauma diagnosis, Class 3. Why?
Its diagnostic value over a thorough and meticulous physical exam in the acute setting is limited, and critically, performing it consumes precious time that should instead be dedicated to definitive treatment or advanced diagnostics.
So if the clinical exam raises suspicion of a significant injury, what's the next step for a definitive diagnosis? CTA again.
Yes. Immediate CTA is a Class I recommendation, Level C, as the primary imaging modality in patients with extremity injury, where significant vascular injury cannot be definitively ruled out by clinical examination. However, this is always with the caveat that imaging must not delay definitive surgical treatment. If preoperative CTA isn't feasible due to instability or time constraints, intraoperative angiography can be used as a substitute.
This brings us squarely back to a concept you stress throughout. Time is limb. What's the absolute critical time frame for revascularization in extremity vascular trauma, and why is it so non-negotiable? This must be key for the exam.
Absolutely. This is an FRCS key concept, revascularization time. Revascularization as soon as possible, ideally within 1 hour of admission, is a Class I recommendation, Level C, for patients with acute ischemia due to extremity vascular trauma.
Within 1 hour. Wow.
Ideally, yes. The stark reality is that there is no safe delay window. Studies unequivocally show that delays significantly increase amputation rates. For every hour of delay, there can be a 10% reduction in successful limb salvage.
Okay.
This imperative means arterial flow, whether temporary or definitive, must be restored prior to skeletal stabilization, fasciotomy, or other procedures, because prolonged ischemia is the primary driver of compartment syndrome and irreversible muscle damage.
Restore flow before fixing bones. Crucial. What if immediate definitive repair simply isn't technically possible? Instability, other injuries.
In such scenarios, the use of a temporary vascular shunt to rapidly restore blood flow in the extremity is a Class I recommendation, Level C.
Shunts again.
Yes. This is crucial when timely primary definitive vascular repair is not feasible due to patient physiology or concurrent skeletal instability. These shunts are a critical temporizing measure, buying precious time while the patient's condition is optimized or other life-threatening injuries are addressed.
When facing the agonizing decision between limb salvage and primary amputation, are there any objective scoring systems to guide this choice, like
Yep.
the MISSIS score?
Another key contraindication for the FRCS. The use of scoring systems, such as the MESS, Mangled Extremity Severity Score, or MESS Mangled Extremity Syndrome Index, when deciding upon limb salvage versus primary amputation for patients with complex extremity trauma is not recommended. Class 3, Level B.
Okay, MEM6 score is out, Class 3.
Why? These systems have consistently been shown not to reliably predict functional limb salvage or to genuinely aid in the difficult decision to amputate or reconstruct. Instead, a multidisciplinary decision-making approach is recommended, Class I, Level B, meticulously taking into account the full extent of limb injury, the degree and duration of ischemia, the patient's overall physiology and comorbidities, and other holistic patient factors that truly influence long-term functional outcome and quality of life.
Multidisciplinary decision, not just a score. Makes sense. What about those less severe, non-occlusive vascular injuries in the extremities, the grade 1s and 2s?
For non-occlusive extremity vascular injuries, ESVS grade 1 and 2, non-operative management with meticulous clinical and imaging follow-up may be considered, Class I, Level C. Many of these non-flow limiting dissections, intimal injuries, pseudoaneurysms, or arteriovenous fistulas have a benign course and will heal spontaneously or stabilize with conservative management, such as antiplatelet therapy.
Okay, non-op might be okay for stable grade 12 and calamity injuries. And for the more significant grade 2, 3, or X injuries, is open surgery always the default? Or does endovascular repair have a role in the extremities?
While open arterial repair remains the most common technique for open versus endovascular repair, ESVS grade 2, 3, and X, endovascular stent or stent graft repair may be considered as an alternative to open repair in selected patients, Class IA, Level C.
Endo might be an option.
Yes, typically for stable patients with suitable anatomy. However, it's important to acknowledge that some studies indicate a potentially higher risk of readmission or reintervention with endovascular approaches in the trauma setting, so patient selection is critical.
What about embolization?
Importantly, endovascular embolization is a Class I recommendation, Level C, for actively bleeding side branches of major arteries, where it is often the quickest and most effective way to achieve hemostasis.
What about injuries to vessels below the knee and elbow? Given the rich collateral supply in these regions, do all injured vessels require repair?
That's an excellent point, and the answer is no, not all. Due to the rich collateral supply in these more distal regions, not every injured vessel requires repair.
Like the radial or ulnar?
Exactly. Ligation is recommended if repair of an isolated radial or ulnar artery injury is not easily achievable and there is no evidence of distal ischemia or hand compromise. Class 1, Level C.
Okay, to ligate radial or the hand is okay. What about below the knee?
Similarly, ligation or embolization of an isolated infragenicular arterial injury without evidence of distal ischemia may be considered if at least one of the anterior or posterior tibial arteries remains intact and patent, Class II, Level C. This avoids unnecessary complex repairs in areas with excellent compensatory flow.
Regarding intraoperative management, should systemic heparinization be routinely used during these repairs? It's often a balance of risks in polytrauma.
Intraoperative heparinization may be considered on an individual basis, Class II, Level C. This is a nuanced decision that involves carefully weighing the extent and complexity of the repair, the anticipated duration of interrupted blood flow, the presence of other concomitant injuries, particularly intracranial hemorrhage, the patient's overall bleeding risk, and the degree of trauma-induced coagulopathy.
Individualized heparin again.
Yeah. The evidence supporting routine systemic heparinization in trauma is conflicting, demanding individualized judgment.
And for extremity venous injuries, like the femoral or popliteal vein, repair or ligate?
Repair of a localized femoral or popliteal venous injury should be considered over ligation in hemodynamically stable patients. Class II, Level B.
Try to repair major leg veins if stable.
Some evidence suggests that venous repair, when feasible, can lead to a lower risk of secondary amputation and reduced rates of chronic venous insufficiency compared to ligation. However, in the chaotic environment of multiple severe injuries or patient instability, ligation may be a more pragmatic and safer damage control option, especially for smaller or less critical veins.
Finally, let's address a major, potentially devastating complication in extremity trauma, compartment syndrome. What are the key points for the FRCS candidate here? This seems critical.
It is. Compartment syndrome and fasciotomy is an FRCS high-yield topic demanding immediate recognition and action. Acute extremity compartment syndrome is a surgical emergency, pure and simple, requiring expeditious management. High clinical suspicion based on the cardinal signs of pain out of proportion paresthesia and increasing tension is paramount.
So diagnose clinically.
Primarily, yes.
Yeah.
Emergency four-compartment fasciotomy is a Class I recommendation, Level B, to treat traumatic post-ischemic lower limb compartment syndrome. Ischemia duration exceeding 2.5 hours is a strong predictor of its development.
Fasciotomy, ASC, if suspected. What about prophylactic fasciotomy?
While early fasciotomy is often advocated, recent research has actually begun to question the universal benefit, prophylactic fasciotomy, in all revascularized limbs, suggesting that careful observation and performing fasciotomy only when clinically indicated may reduce unnecessary surgical morbidity. This is a subtle but important shift in thinking.
Interesting. Observe carefully. Don't just cut prophylactically on everyone. What about post-operative surveillance for these repaired extremity injuries?
Post-operative clinical examination and duplex ultrasound 1 month after repair, or earlier if abnormal findings or symptoms develop, may be considered for patients with extremity vascular injury who have undergone vascular reconstruction. Class I, level C.
US at 1 month check.
Yes, this helps to diligently monitor for complications such as thrombosis, restenosis, pseudoaneurysm formation, or arteriovenous fistulas, ensuring the longevity and success of the repair.
Children are certainly not just miniature adults, and their vascular trauma management comes with its own distinct and often intricate set of challenges. What should our listener understand about pediatric vascular injuries, which are often less common but uniquely complex?
This is a truly crucial area, often overlooked in adult-centric guidelines. And for an FRCS candidate, recognizing these profound distinctions is vital. Pediatric vascular trauma is, thankfully, rare, and consequently, clinical evidence is often limited, requiring highly individualized and careful approaches based on expert consensus and extrapolation from adult data.
What are some of those unique considerations that make managing vascular trauma in children so different?
The general considerations are manifold. Firstly, children have significantly smaller vessel sizes, which makes surgical repair technically more demanding and predisposes them to vasospasm and thrombotic occlusion.
Right, smaller vessels, spasm prone.
Exactly. They also possess a limited intravascular volume, making them exquisitely susceptible to rapid decompensation from blood loss. Crucially, any intervention must consider the long-term need to accommodate future vessel growth, both longitudinally and circumferentially, and ensure the long-term durability of the repair.
Growth potential is key.
Absolutely. Interestingly, children's effective compensatory physiological mechanisms can sometimes justify a period of non-operative management for certain minor injuries, particularly if growth potential is a concern.
And for diagnostics in this younger, more vulnerable population, particularly with radiation exposure being a greater concern, is CTA still the way to go?
Similar to adults, CTA is recommended as the first-line investigation to identify or rule out vascular injury in hemodynamically stable pediatric trauma patients, Class I, Level C. However, this is always performed with a heightened awareness of radiation dose optimization, utilizing pediatric protocols and striving for the lowest possible exposure.
Okay, CTA, but be careful with dose. What about the actual repair techniques for children, given the critical factor of ongoing growth? How does that influence the choice of repair?
For repair techniques in children, vein grafts may be more suitable for small caliber vessels due to their biological compatibility and potential for growth.
Vein grafts might be better.
Potentially, yes. Furthermore, interrupted sutures are often used, rather than continuous suturing, to prevent post-operative stenosis and to specifically accommodate future vessel growth.
Interrupted sutures to allow growth. Makes sense. What about stents?
Experience with stent graft repair in children is very limited, and crucially, long-term results regarding their durability and impact on growth are generally unavailable, making them a less common definitive treatment.
Okay, limited data on stents in kids. Let's discuss neck vessel injuries in children, particularly blunt injuries. Similar to adults,
For neck vessel injuries in children, the incidence of blunt cerebrovascular injury, BCVI, may be similar to adults. Early antithrombotic therapy is recommended, Class Y, Level C, for children with blunt, low-grade carotid artery injury, Grade 1 or 2, again to prevent thromboembolic complications.
antiplatelets for grade 12 BCVI in kids too.
Yes. For Grade 2 or 3 injuries with an enlarging pseudoaneurysm or active bleeding, embolization or open repair are viable options, chosen based on the child's specific anatomy and the extent of injury. Long-term follow-up is absolutely essential for monitoring arterial remodeling and ensuring appropriate vessel growth.
And blunt thoracic aortic injury, BTAI in children. It's rare but incredibly severe. Can TEVAR be used?
Thoracic aortic injury is indeed rare in children.
Correct.
While significant challenges exist due to the often small diameter of the aorta and peripheral access vessels, as well as potentially hostile arch configurations, endovascular stent graft repair should be considered as the first-line operative treatment for children with grade 2 or 3 BTAI and appropriate anatomy, Class 2 Level C.
Okay, TEVAR might be first line even in kids if anatomy fits.
Yes, it often serves as a life-saving or bridging procedure in the acute setting. However, the long-term effects of stent grafts on aortic growth and vascular remodeling in children are still being actively studied, representing a significant gap in our current knowledge base.
How about abdominal vascular injuries in children? Do we simply follow adult protocols there?
For abdominal vascular injuries, management strategies generally parallel adults, but the operative modalities are profoundly challenged by vessel size. This necessitates meticulous attention to appropriate graft and device selection to prevent narrowing due to growth, often requiring specialized pediatric instruments and techniques, such as beveled anastomoses with interrupted sutures.
Okay. Similar principles, different technical challenges. And for the extremities, what's the approach to pediatric extremity vascular trauma, particularly for that classic anxiety-inducing scenario, the pink pulseless hand after a supracondylar humeral fracture?
Yes, the pink pulseless hand. For extremity vascular trauma in children, a clinical vascular examination meticulously performed in line with adult guidance is a Class I recommendation level C. Regarding the pink pulseless hand post-supracondylar humeral fracture reduction, a scenario every FRCS candidate knows, non-operative management with close observation should be considered, Class C, level C, unless clear signs of acute irreversible ischemia develop.
So watch carefully, even if the pulse is gone, as long as the hand looks okay.
Often, yes. This approach acknowledges the high incidence of vasospasm and the excellent collateral circulation in children, often avoiding unnecessary re-exploration. A multidisciplinary team involving both orthopedic and vascular specialists is crucial here for shared decision-making.
Lastly, what are the critical postoperative considerations for children after vascular trauma? Antithrombotics. Follow-up.
For postoperative considerations, a standardized antithrombotic protocol specifically for children is, regrettably, still lacking. Aspirin or weight-based low molecular weight heparin have been suggested, but evidence is limited.
No standard protocol.
Unfortunately, not yet. Post-operative follow-up with clinical examination and duplex ultrasound 1 month after repair, or earlier if symptoms arise, may be considered for children with extremity vascular injury reconstructed with bypass or interposition grafts, Class IIB, Level C. Crucially, routine CTA surveillance should be avoided if not absolutely necessary due to the long-term radiation exposure concerns in this younger population.
Beyond the immediate acute interventions we've discussed, what are the broader postoperative considerations for vascular trauma patients? And perhaps most interestingly, where do these guidelines point us for future research and evolving practice?
Postoperative care for vascular trauma, while adhering to general trauma management principles, demands particular attention to constant monitoring, seamless team communication, and aggressive complication prevention.
So what's the regimen for ongoing monitoring during that critical initial postoperative phase? What are we looking for?
Regular, meticulous evaluation of vascular status through repeat physical exams, handheld Dopplers, duplex ultrasound, and selective CTAs is paramount for the first 24-48 hours.
Checking perfusion constantly.
Yes. We also continuously monitor coagulation parameters, aggressively manage potential rhabdomyolysis with laboratory blood tests, and maintain constant vigilance for the development of compartment syndrome, which, as we discussed, can be a delayed reperfusion injury. Prophylactic measures, such as graduated compression stockings and early aggressive physiotherapy, are also crucial not only to prevent deep venous thrombosis, but also to promote functional recovery.
Is there specific guidance on antibiotic prophylaxis after vascular trauma, or does it fall under general trauma recommendations?
For antibiotic prophylaxis, there is no specific evidence for or against postoperative antibiotic prophylaxis solely for vascular trauma beyond general trauma recommendations.
So individualize it.
Individualization is strongly advised considering the trauma setting, e.g. civilian versus military, clean versus contaminated wounds, the specific injury types, e.g. open fractures, and the treatment environment. For an FRCS candidate, understand that this is a gray area requiring clinical judgment.
And for postoperative and antithrombotic therapy, after the repair itself, what's the consensus? Is it similar to non-trauma vascular surgery?
Not really. This is an area with truly limited and often conflicting literature. Recommendations from atherosclerotic disease, for example, absolutely cannot be generalized to trauma patients, who often have complex coagulopathies and high bleeding risks.
Right. Trauma coagulopathy is different.
Very different. Therefore, an individualized postoperative antithrombotic strategy may be considered, Class I, level C, with single antiplatelet therapy. This decision demands a careful balance of the competing risks of hemorrhage and thrombosis of the reconstruction, assessing patient-specific factors such as overall bleeding risk, thrombotic predisposition, and the complexity of the vascular repair itself. Practices vary widely, so careful consideration and multidisciplinary input are key.
These guidelines are incredibly comprehensive, yet you always hear about areas where more research is critically needed. What are some of the most pressing gaps in evidence and recommendations for future research that these guidelines highlight? This is where an FRCS candidate can truly demonstrate a deeper, consultant-level awareness of the field's limitations and future directions.
Absolutely. Acknowledging these gaps is crucial for consultant-level understanding and future practice. The guidelines highlight numerous areas urgently needing further large-scale prospective studies and robust randomized controlled trials.
Like what specifically?
Well, defining the optimal duration of temporary intravascular shunts and their long-term impact. A much better definition of specific patient populations who would truly benefit from a REBOA, moving beyond its current limited routine use to more precise indications. More robust data on the long-term patency and durability of endovascular stents and stent grafts when used in a younger traumatized population. Assessing the precise role and efficacy of novel graft materials like bovine or human acellular matrix.
Okay, what else?
Identifying optimal antithrombotic regimens and the ideal follow-up imaging intervals for various vascular injuries. We really need better comparative studies there. Clearer risk factors for early aortic rupture in BTAI, and a more precise understanding of the ideal timing of operative intervention for all grades. Developing optimal management strategies for mesenteric vessel and renal vessel injuries, where high-level evidence is particularly sparse.
Big gaps in mesenteric and renal.
Yes. Conducting comparative studies of open versus endovascular repair for extremity trauma, including rigorous assessment of long-term functional outcomes. Understanding the impact of different operative strategies for extremity venous injuries, specifically the long-term benefits of repair versus ligation. Developing standardized follow-up protocols and clear antithrombotic regimens for pediatric vascular trauma. And finally, a better definition of adequate and patient-centric clinical trial endpoints in vascular trauma to ensure future research is truly impactful and relevant to patients' lives.
That's a truly robust and insightful list. It powerfully highlights that even with these meticulously crafted guidelines, the field is continuously evolving, demanding ongoing research and critical thinking. Beyond the purely medical interventions, what's the broader patient perspective on navigating life after vascular trauma? It's a journey that extends far beyond the operating room.
Yeah, absolutely. Ultimately, vascular trauma is a profoundly serious condition, carrying significant and often life-altering risks of both life and limb loss. While modern multidisciplinary trauma care in specialized centers undoubtedly improves immediate outcomes, patients face substantial and often protracted challenges in their recovery.
Like rehabilitation.
Yes, intensive, long-term rehabilitation, significant socioeconomic barriers that impact their ability to return to work or daily life, and profound psychological impacts such as PTSD or anxiety. This underscores the absolute necessity for comprehensive, patient-centered care and sustained long-term follow-up that addresses not just the physical injury, but the entire person, encompassing their mental and social well-being.
And that, listeners, has been our deep dive into the ESVS 2025 Clinical Practice Guidelines on the Management of Vascular Trauma. From the initial CABCDE approach and the crucial early decisions, through the nuanced specifics of repairing individual vessels, it's clear this field is a dynamic testament to the power of rapid, evidence-based, and informed action.
For our FRCS candidates, and indeed any clinician involved in the high-pressure environment of trauma, the key takeaways are manifold. A steadfast commitment to evidence-based practice, the absolute imperative of time-critical decision-making, a mastery of the ESVS grading system, and a keen critical awareness of both recommended interventions and, crucially, those to be actively avoided.
Right. Knowing what not to do is just as important.
Exactly. These guidelines aren't just a rule book. They are there to empower you to achieve the best possible outcomes in the most challenging scenarios.
So what does this all mean for you, the learner, taking this knowledge forward? It means that even with the most meticulously developed guidelines, the indispensable human elements of critical thinking, continuous learning, adaptability, and seamless multidisciplinary collaboration remain utterly irreplaceable in the face of vascular trauma.
Indeed. The enduring question for us to continually ponder is this: As technology advances and our understanding deepens, how can we further refine our diagnostic and decision algorithms, not only to save more lives and limbs, but also to guarantee the highest possible quality of life and long-term functional recovery for every single patient we treat? It's a challenge that defines the future of our specialty.
A truly profound thought to carry forward into your practice. Thank you for joining us on the deep dive. We trust this has equipped you with the critical insights you need to excel in this vital field.